so we can give Dr. Box all the time that he needs and deserves. My name's Heather Hylas, and I'll be moderating the afternoon sessions. Welcome to the 68th Annual Ogden Surgical Medical Conference here in Ogden. Dr. Terry Box is an associate professor in the Department of International Medicine at the University of Utah School of Medicine. He is also a Huntsman Cancer Institute investigator and a member of Huntsman's Gastrointestinal Cancer Program. Dr. Box is certified by the American Board of Internal Medicine and the National Board of Medical Examiners. Dr. Box's expertise is in diagnosing and treating diseases of the liver. He has specific expertise in hepatitis B and C, hepatocellular carcinoma, and liver transplantation. Dr. Box completed his medical degree at the University of Texas Southwestern, followed by residency and fellowship at the University of Utah. He is the medical director of the liver transplant program and director of Project ECHO at the University of Utah. Dr. Box.
Thank you very much. It is indeed a pleasure to be here with you today and to talk about one of my favorite subjects in general hepatitis C, and specifically about a very innovative approach to spreading the word and the knowledge and trying to deliver health care where it heretofore hasn't been widely available, and bring on a whole new set of folks who are very capable in treating hepatitis C. I am indeed impressed with the magnitude of this undertaking. I've only lived in Utah since 1977, but I had no idea such a wonderful conference occurred just a few miles up the road from Salt Lake City. So I commend all of the organizers, and I do indeed appreciate the opportunity to be here. If I am intelligent enough, I can probably figure out how to make this work. One looks like a laser. Is this the advancer as well? Yes, must be. No, maybe I just turned it off. How about that? Sorry. This guy. Oh, the one with the arrow on it, of course. I have been fortunate enough to be able to participate in a lot of clinical research, and most of my disclosures are related there too. I do speak for many of the companies who are involved in hepatitis C research and consult for Cadmon as well. So, during this talk, you're going to see estimates of the prevalence of hepatitis C in the United States all over the map. You'll see estimates as low as 3 million people and as high as 5, so we're going to start with 4, but I'm just warning you it will change during the talk, and it's not because I'm having little mini strokes. That's just, as you change your reference, you change your number, so to speak. The good news is, as opposed to the 1970s and 1980s when we had 150,000 new cases of hepatitis C annually, we have only 35 to 40,000 new cases annually in this country now, and most of those are related to IV drug use. 85% of the cases become chronic. 5 out of 6 become chronic. If you're infected, you have an overwhelming likelihood of carrying this virus with you. And as you see from the last bullet point and the sub-bullet points below that, hepatitis C is the cause of a lot of morbidity. Glossary of terms, just in case you're not familiar with all of our terminology when we talk about hepatitis C. There's the term PCR, which stands for polymerase chain reaction, which is a test used, it's a method used to measure active viral replication, ongoing viral replication. Hepatitis C is like a family, many members of the family. They're related, but they're not just alike. There are 6 genotypes of hepatitis C virus. There are subtypes of 3 of those genotypes. The genotypes are like cousins. They're related, they're not real close. The subtypes, however, are very much related like siblings. So we'll talk about genotype 1, genotype 2, genotype 3 in this country, which, as you see, comprises almost all of the genotypes prevalent in the U.S. right now. However, as more and more immigrate into this country from parts of the world where genotypes 4, 5, and 6 are common, the small 1% will grow bigger. But genotype 1, most common by far, most challenging to treat by far. So that's our story in the United States. Subtypes are measured after the PCR has been performed. The PCR actually allows the virus to continue to replicate in the test tube with markers indicative of the additional add-on of matter into the viral replication. They're marked with a little fluorescent protein, and then there's some dehiscence involved, and you put them up against a plate that defines the subtypes. So PCR is replicating virus, subtype determination, and hence we can define genotype 1A, genotype 1B, 2A, 2B, and so forth. This is indeed a common disease. It affects at least 2% of the United States population. It's potentially quite progressive, as we have already heard, associated with cirrhosis, liver failure, hepatocellular carcinoma, to name the 3 at the highest end of the spectrum. In the past, this was a disease that was not curable. For the last several years, however, this is a curable disease, and I want to say this again, and I'll continue to say it. It is a curable disease. It will go away and not come back. We can cure it. It doesn't matter what the liver injury tests are. It doesn't matter what the ALT is. This is a bad disease. We need to work on it. We need to identify it. We need to treat it because we can cure it. If we cure it, we reverse a lot of the bad things that have happened to the liver, including advanced fibrosis. SVR, or sustained virologic response, which is the definition of cure. That means there is no virus 6 months after you stop treatment. The SVR, the cure, reduces the risk of liver failure, liver cancer, and the need for liver transplantation. This is a nice bar graph showing you the futility almost of early interferon therapy back in the early 1990s when we really didn't know what we had or what to do with it. As you see, we extended the duration of therapy. We added ribavirin to it, made it better, almost ineffective in all but 6%. All of a sudden, 7 years later, we're up to 34%. We make it long-acting by making it pegylated. Put ribavirin with it, you're up to 55% overall, 40% for difficult-to-treat genotype 1 patients. And then here we have the third drug, the direct-acting antivirals, about which we're going to speak. And we have now gone from 6% to 12 times that, over 70% likelihood of sustained virologic response, sustained cure in managing hepatitis C. And there aren't a whole lot of viral diseases that are of significance that over the last 20 years we've gone from 0 to 75% cure. So this is a remarkably fast-moving field. It's so fast-moving now that when I handed my slides in March for this talk today, I had no idea how outdated some of them would be by today. So things are moving very quickly. SVR 24, sustained virologic 24, means 24 weeks after cessation of therapy. We check again for activity of virus. We do the PCR test. We check for the RNA. And once it remains non-detectable at week 24, we call that good. We consider that a clinical cure. As I've stated, you get improvement of the fibrosis, you get resolution of the inflammatory response. For those who were already cirrhotic, you get some lessening of the fibrosis, and you start to reduce the high pressures in the portal system and begin to lose some of the other adversities of having advanced liver disease secondary to hepatitis C. We now have 20 plus years using interferon. We haven't always used it well, but we've learned a lot in the last 20 years. And so we're getting much better with it. And even today, with the new direct-acting antivirals that we're going to talk about, this is a regimen based on interferon. If you don't have interferon in the regimen nowadays, it doesn't work. You never use these two new drugs alone. There are issues with 3-drug therapy that we didn't have to deal with in the past with interferon and ribavirin. A whole lot more, many, many more drug-drug interactions. So there are some minuses to go along with the wonderful pluses. Old therapy. Almost a year's worth was needed to cure difficult-to-treat genotype 1. 48 weeks of therapy with interferon injected weekly and ribavirin taken daily. And if you have tried treating this, if you have personally experienced this, was 48 weeks of hell. It's toxic. It's chemotherapy-like toxicities from interferon and ribavirin. Well, the new drugs have given us a new outlook. We can now look at shortening therapy considerably, as we will see. During our years managing interferon and ribavirin, we have gotten good at managing adverse events, and that's where we still need to be, because every time we add a drug, we add a new level of complexity, we add a new level of adversity, and so even with this new outlook, better numbers, shorter duration of therapy, we have a lot of adversity with which we must still deal. However, very doable, a lot of success. So genotype 2 and 3, I'm going to mention it here and probably forget it the rest of this talk, because the new drugs are focused exclusively on genotype 1. They don't work on the other genotypes. The future is brighter for 2 and 3. But genotype 2 and 3 still is managed in the traditional way with 2 drugs, pegylated interferon and ribavirin, just as genotype 1 was prior to 2 years ago. It is a shorter duration of therapy because they're easier to treat. Instead of 48 weeks, it's 24. Good news. Some who respond very robustly can even get away with shorter durations of treatment, such as 16 weeks. For genotype 2 and 3, as I indicated, even though we don't have a new drug for them, they're not to be left out. Actually, in front of the FDA right now are 2 new regimens to manage genotypes 2 and 3, one of which is interferon-free. So the day is coming where we'll get rid of interferons, and earlier than later for genotypes 2 and 3. We'll have shortened therapy because therapy is more potent. We get a more robust response. We don't have to treat for so long, and hopefully with fewer adverse effects. The class of drug that now is used for genotype 1 hepatitis C infection combined with pegylated interferon and ribavirin are called protease inhibitors, and we'll see a little breakdown of the virus itself to help you understand what the protease inhibitor does. The 2 drugs are called boceprevir and telaprevir. They're both out of the same class. They share many, many things in common, including the same toxicities across the board. The recommendations for which groups we should treat with these drugs are the same. All groups should be considered for treatment. That means patients who have been previously treated but didn't respond so well should be treated. Those patients previously treated who relapsed should be treated. Patients who have been previously not treated certainly should be considered for treatment. We can hopefully check on the response early on, determine who doesn't need 48 weeks, who can be terminated at 24 weeks, cutting 6 months of agony out of the treatment course. With both of these drugs, that's a possibility, response-guided therapy. And they both do better if you consume them with food. The telaprevir actually needs a pretty high fat intake. As a matter of fact, I challenge you, as good as it sounds, to eat 20 grams of fat with all 3 doses of your telaprevir every day. That's only an additional 540 calories of donuts and ice cream and peanut butter and cream cheese. And interestingly enough, for the 12 weeks that goes on, that becomes one of the main complaints of patients. They like it when they see it, but not when they do it. There are some differences in the administration between these 2 drugs, but by and large, the outcome is the same. These technical aspects are not what I really want to focus on today. I just want to introduce to you the concept of a direct-acting antiviral added to the more traditional therapy, interferon, which upregulates the immune system without specifically attacking the virus, and ribavirin, a pill, which does the same. So 2 immune modulatory drugs add a very potent direct-acting antiviral, and we're going to see in a minute what that means, and you have a better outcome. You go from 50 to 75% likelihood of cure. In the blue bars are the outcomes in the trials that were used to get both of these drugs approved. Now, you never have the same placebo groups in one trial or the other, so you really can't compare results. The difference between the placebo group and otherwise the delta was the same whether it was boceprevir or telaprevir. The good news is that in every group studied, as I indicated, the placebo group did much less well than the treatment group. Placebo group 40%, 70% treatment group in all comers treatment naive. If you're starting out treating this, you'd like to have success. If you want to choose for success in managing these patients, go for the patients who've previously demonstrated some response to interferon and ribavirin, add the DAA, add the direct-acting antiviral, you're going to do a whole lot better. Look at this, relapsers. These are people previously responsive, but when the treatment was removed, the virus came back. They weren't cured, but they were responsive. You add the 3rd drug, this is what happens. You go from a 25% likelihood of relapsers responding permanently to an 80+% chance. Partial responders are those who never completely responded previously, and they have a significantly higher likelihood of response. And even the very difficult to treat people who were only marginally responsive to interferon and ribavirin get up to 30-35% likelihood of response. So that's why I say all people with hepatitis C should be considered, even cirrhotics, who are a unique group, not the group you want to start out with, but they're a unique group that will indeed respond better with the 3 drugs than with the 2, though extreme caution has to be exercised in managing these patients. Response-guided therapy. Therapy that will be shortened in response to an individual's robust loss of virus early on. So, focus on the red. The red is really the key of this slide. A lot of words, details not important for you, but what happens is you pick an arbitrary point early in the course of this previous 48-week treatment course, and if you see a PCR that goes completely away at a couple of time points, which are 1 month and 3 months, or 2 months, it's absolutely non-detectable. And these tests are very, very sensitive, measuring down to just, dozens of units per milliliter of blood. You get a sensitive assay, it goes to complete non-detectability at week 4 and 12 of triple therapy with telaprevir. You get to shorten your treatment course to 24 weeks without any loss of efficacy. You still get this very high number at the end. In fact, if you qualify, and 60% of the patients do qualify for response-guided therapy with both drugs, either one. If you're in that 60% and you get only 24 weeks of therapy, if you've had that kind of response, then your likelihood of success goes to 90%. You remember overall was 60 in the treatment naive, 80-something in the relapsers. If you're in that 60%, however, that had that very robust response at weeks 4 and 12 with telaprevir, or week 8 and maintain it on boceprevir, then you've got a 90+% chance at the end of your 24 weeks of therapy of being cured. That's what excites people so much. So this is just a diagrammatic presentation of what I was attempting to describe for you. So with boceprevir, you actually have a 4-week lead-in where you only use the traditional therapy of pegylated interferon and ribavirin, and then you add your third drug. And here, if you're undetectable at week 8 and you don't lose that undetectability throughout, then you terminate it after 24 weeks of triple therapy at week 28. With patients who were not so robust in their response, then you go out to week 36 with 3 drugs and add 12 more dual. Not so important you remember those details. A little bit different with the telaprevir. Due to the fact there's no lead-in, you just get 12 weeks of triple therapy followed by 12 weeks of dual therapy if you had this robust, extended, rapid virologic response. If there's any detectability at week 4 or thereafter, you go out to 48 weeks, but only the first 12 of which are triple therapy. With every bit of good news comes a little bit of bad news. Not everybody responds. No good deed goes unpunished. And so what we have here are what we call futility points. And the futility point with boceprevir is if at treatment week 12, you have more than 100 international units per milliliter, you stop. Because we know it's not going to work if there's still any virus that we can detect. And that means there may be 12 IU per ml, but we don't have a test that's sensitive. But if it's over 100, what we know is that it's not going to work because those 100 IU per ml are resistant variants that have developed in response to this therapy, and there's nothing you can do, you give it up. If you are under 100 at week 12 but not non-detectable, or if you were non-detectable and all of a sudden something pops up at week 24, then it's over. And similarly, with telaprevir, you have the same futility. The numbers are different, but philosophically, it is the same. So, in the middle is what the typical patient is like on interferon. So that's why interferon has such a bad rap. You get patients out there who have read about interferon, they don't want to be treated regardless of how good things are. They know something's coming down the road with no interferon and they want to wait. Well, hopefully we can accommodate most of those people. But as you see, a lot of these symptoms sort of look like an upper respiratory tract illness, influenza, arthralgias, they get depressed, they feel bad. There's always been a little anemia with these regimens, but when we threw in that third drug, the anemia became severe and in some cases life-threatening. And rash, which is a problem with all medications, but particularly with ribavirin for starters, and throw the direct-acting antiviral on top of that. There have actually been deaths associated with severe skin injury in these treatment regimens. So again, with boceprevir, these are the 3 most common adverse effects that occurred more commonly in the treatment group than the placebo group. And as you see, anemia, about which we've spoken, is 30% placebo group with peg-riba. You add the boceprevir, it goes up to 50%. And this anemia means that the hemoglobin dropped below 9 grams per cent. It's not trivial stuff. Neutropenia, more common in triple therapy, and then a bad taste in their mouth, such that nobody really wants to eat, occurs in a third of the patients. So these are not small-time adverse events. With the telaprevir, you see that the rash about which I spoke is a huge issue here, occurring over 56% of the time, but the ribavirin rash occurs a third of the time. Anemia occurs twice as often, numerically not quite as great, but it's still a big deal. And the GI side effect with telaprevir is more lower GI than upper GI, as it was in the boceprevir. So in the registration trials, the dropout rate on therapy was less than 10%. In the trials that we showed the FDA to convince them that these drugs were good, the dropout rate was less than 10%. Is that reality? No, it's not reality. So I'm going to demonstrate for you here what is reality out in the community. When these drugs finally make it out past the investigational stage, this is what happens when we start using them. So as you learn how to use these drugs, you certainly don't treat everybody who comes along. So in this study that was reported in abstract form at the liver meetings in 2012, out of 500 genotype 1 patients evaluated for triple therapy, 407 of them were not treated. That says something. I'm not sure what. Well, they weren't treated for a variety of reasons, but these were the three most common reasons they were not treated. Their disease was so mild, they didn't want to go through the agony of the treatment, perhaps, so they chose not to treat. For whatever reason, even though their disease might have been more progressed, they chose not to be treated, or they just wanted to wait for better therapies. However, there were 91 of them who did go on therapy in Dr. Chen's report. And as you see, 21% dropped out before week 12. So again, we have very good treatment. It's very harsh. It's still not as good as it can be, and we'll talk a little bit of what's yet to come. In another study, it was even more impressive. The dropout rate before week 12 was 33%. So we have work to do. As good an image as I presented early on, we still have work to do with this. Another issue that comes up with the triple therapy, with the new direct-acting antiviral therapy that we didn't have to worry about so much with PEG-RIBA, is drug-drug interaction. And the interaction is all over the map. Sometimes the interaction between the drugs raises the non-DAA to toxic levels. And a specific example of that I will show you are the statins. Certain statins given with either telaprevir or boceprevir are elevated to such high levels that toxicity becomes a real problem. So those statins have to be avoided during this. There are other issues. Sometimes the other drug drives down the efficacy of the direct-acting antiviral. And the reason is most drugs share common metabolic pathways with the direct-acting antivirals. The cytochrome P450 system is responsible for 80% of the drugs, metabolizing 80% of the drugs that we ingest, and it's no less important in boceprevir and telaprevir. So there's a lot of competitive inhibition to try to get both drugs through the pathway simultaneously, so to speak. Whoever wins that battle is going to be metabolized. The other one is going to elevate in toxicity. Or some drugs upregulate the P450 system and then metabolize the direct-acting antiviral drug quicker, lessening its efficacy. As busy and as noxious as this is not anywhere near the complete drug-drug interaction profile. But I will point out to you that and these are absolutely contraindicated drugs. They're not relatively, but absolutely contraindicated. You're not using many of these drugs. Our hepatitis C patients aren't using many of these drugs. They're using some of these, so we have to avoid the traditional management for migraine headaches. A few years ago, a lot of them were using St. John's wort for depression, but I think that fad has passed. Lovastatin, simvastatin are the statins that you're going to have to avoid. Down here where you're looking at phosphodiesterase inhibitors, these are doses of these drugs that are much higher than those used for erectile dysfunction. So they're still usable in erectile dysfunction, but not if you're using phosphodiesterase inhibitors to treat pulmonary hypertension. I've mentioned the word cirrhosis several times. Patients with cirrhosis are a challenging group for a lot of reasons. They come into the equation sick. They may be sicker than we think if they've never had an episode of decompensation. Sometimes, unless we biopsy everybody, we're even caught off guard and we don't know they're cirrhotic until we start treating them, and then they blow up. They get ascites, they become encephalopathic, they may have a GI bleed from varices. So, there's a European group looking specifically at cirrhotics. Cirrhotics historically have never responded to any treatment as well because the liver doesn't work. So, encouragingly, there are high frequencies of on-treatment response, but only after 16 to 20 weeks. And all cirrhotics, by the way, even in the triple therapy era, are going to be treated for 48 weeks. Not any of them qualify for response-guided therapy. These are on-treatment responses. We haven't seen the relapse rate, which I guarantee you will be higher by a factor of 2 or 3 than the relapse rate, which is about 8 to 12% in treatment-naive non-cirrhotics. However, look at this high rate of serious adverse events. 50% with telaprevir, 40% with boceprevir, and these are serious adverse events. These are adverse events that put people in the hospital, that put their life in jeopardy sometimes. High rate of anemia, we've already seen. That's a bad thing to go along with cirrhotics who might bleed. And now we're getting up into big numbers of premature termination because of the adverse events. And I will just point out to you that the likelihood of dying of these patients, of these cirrhotic patients dying on triple therapy, is not inconsequential. So my advice to anybody who wants to treat a cirrhotic is refer them to your favorite transplant center before you do, just in case they go south in the middle of treatment. So, summary of triple therapy. You can read this as well as I. I just want to point out to you that I don't know how to do this. That's what I want to point out. In spite of significant progress using boceprevir or telaprevir-based triple therapy, there are several challenging impediments to universal application in all HCV patients. So, you don't need to read this. I just put it up here because these are the bars that I showed you earlier on how to determine response-guided therapy. This isn't easy. Does anybody feel like I've adequately explained it? Now, that's not because I'm not a good explainer, right? It's just because I went through it fast, right? So anyway, these are challenging. It's challenging for the provider. It is also challenging for the patient. Look at this pill burden. Look at this pill burden. That is 12 pills that must be taken, 12 boceprevir pills every day. Every day. 4 pills every 8 hours. And then on top of that, you've got to add 6 more ribavirin pills every day. We know that the greater the pill burden, the less likely adherence occurs. If you don't adhere, you don't succeed. And as I said, eating this much fat for 12 weeks every day. Look, I know, you think you like this, don't you? Well, you don't. Anyway, eating this much fat is a problem. So we have a lot of challenges. And in addition to all of these challenges up here that we've discussed, including the rampant DDIs, there's limited activity, as we've already pointed out, with our current protease inhibitors in non-genotype 1 patients, as well as HIV co-infected patients, post-liver transplant patients, and patients with advanced renal disease. So the future of therapy, where are we today? Or where will we be 1 year from today, I should say. And it will be 1 year from today where we are into the future, because things are going to happen near the end of this year or the first quarter of 2014, because there are, as I said, 3 new treatment regimens in front of the FDA. So the challenges we have outlined, the pill burden, 3 times a day dosing. Who takes medication in this room that you remember every day to take it 3 times a day? I take medication twice a day. If I don't set my cell phone for the second one, I forget, and I should know better. Response-guided therapy. Well, that's great, but it's kind of complex, right? Why don't we just get everybody down to shortened duration of therapy? Different therapies based on genotype. How about one drug for all genotypes? Interferon, we've already bashed it. We know that's bad. Well, here are the investigational strategies ongoing right now that address every one of those. So when you think about developing drug development strategies, research strategies, drug dosing strategies, this is how you build it. And so make it simple. Cover all genotypes with the same regimen. Obviously, we want it to be very safe and tolerable. Get rid of the interferon. Highly effective. You know, not 70%. We want 98, 100%. And then the ultimate. One pill, once a day, short duration, highly effective. We're not there yet. We're not nearly there yet, but we can work on it. Quick cartoon of the hepatocyte, of the liver cell, and what the virus does once it gets in there, and how this works for us to develop new strategies to continue to improve our outcomes in treating these patients. The virus has to get in there. This little white blob is the virus in a little membrane. It has to hit a receptor, come into the cell, then uncoats the RNA, which is then translated by host proteins into a thing we call a polyprotein, which has several different components that set up shop in the endoplasmic reticulum where the viral replication occurs, and then it gets packaged and kicked back out. Well, along the way, if we interfere with protease inhibitors, and we have 2 of those now and more on their way that are better, or if we interfere with so-called replication complex formation with inhibiting this structure, or another step in putting the virus together, making new strands of RNA before it gets encapsulated in the endoplasmic reticulum and kicked out. If we interfere with any or all of these, or any combination thereof, we're going to stop the virus from replicating. If we can really lean on it aggressively, early, hit it hard, hit it fast, we're going to do a better job than 75%. So, there are interferons that are being looked at that are as good as our current interferon, but much less toxic. We've talked about viral agents and described the different targets. We have current protease inhibitors, second generation on the way, polymerase inhibitors, and replication complex inhibitors. We're looking at how to just prevent the virus from getting into the liver cell. The reality is this virus can float around in your blood forever. It doesn't hurt you. In fact, it gets into other organs. It doesn't hurt those other organs. It only affects the liver, though it can hide in those places, and we have to get to those places. And that's why we have to treat for so long. Cyclophilin is a host protein that helps the virus translate that long polyprotein, so this cyclophilin inhibitor investigation is ongoing. So those are some of the areas in which we're looking. And this just outlines the benefits versus the drawbacks in these various areas that we've described that are important to drug development. It really looks like our NS5B or our polymerase inhibitors, if you were just to pick one drug, that's what you'd pick. This has the best profile. If you pick this drug and a second generation protease inhibitor, you may cover the waterfront. Well, that's exactly what's in front of the FDA right now. But interferon, by and large, is still used. We haven't hit the magic 1 pill a day yet. But this is how these things are analyzed to try to develop the best drug that avoids or improves all of these issues. Again, don't worry about the detail. This just tells you what's going on, and this is only a smattering of the number of investigations that are ongoing. But I will tell you this. The future will be 12 weeks max therapy. Duration will be 12 weeks except for cirrhotics. It will be interferon-free instead of having to wait for 6 months After therapy, to declare success, we're going to wait for 12 weeks or 3 months. We're going to have SVR. It will be interferon-free. It will be a few pills, but maybe we can put it all into one, a combo pill. So we're getting there. We always like to tease you with small numbers. I'm sorry this number dropped out, but it's 40. So polymerase inhibitor, and this is actually one of those replication complex inhibitors. 44 patients, very difficult to treat, genotype 1, SVR24, this is cure, 44 patients, everybody responded. That's what got people excited. Genotypes 2 and 3, about the same. And then in treatment-naive patients, again, interestingly, genotypes 2 and 3 don't work quite as well as 1, but these are extremely encouraging numbers. These regimens are not ready for prime time yet, but that's where people are looking. They're looking at polymerase inhibitors, NS5A inhibitors, and this was just structured in a funny way with polymerase inhibitor alone, and we know that that's more likely to develop resistance, and I think that's why these numbers are a little bit lower than when you went at it with 2 drugs for the entire duration. For those people who see these patients and talk to them about treatment, they're encountering patients who want to just sort of retreat from active consideration. And in many patients, that's appropriate. But there are some for whom treatment now should be considered because they have advanced disease. We don't know for sure what's going to happen with the FDA. We don't know for sure how safe and effective these drugs will be when we really get them out on the market. If there's a delay, you may miss the opportunity to prevent somebody from becoming cirrhotic. So we're not entirely ready to put everybody in a warehouse and wait for 2014 or 2015, but a lot of patients are making that decision. The reason that I'm a little bit skeptical is just outlined for you here. They're small studies, toxicity issues, minimal data, so don't celebrate yet. But this is good. It's really good. So why aren't we treating more patients? Why haven't we gotten rid of hepatitis C? Well, they're hiding in plain sight because 3/4 of the patients with hepatitis C don't know they have it. I don't know, I know. Hep B, 2/3, I don't know, I know. HIV, 80%, I know. Why? We don't screen well. We don't screen. Primary providers, you should be screening for hepatitis C, hepatitis B. Do you screen for hypercholesterolemia? Do you screen for breast cancer? If you have a practice of 2,000 patients, even with the most conservative estimates, you have 40 patients with hepatitis C in your practice. This is what happens to a hepatitis C liver after about 25 years. Advanced fibrosis, leading to cirrhosis, leading to liver failure, need for liver transplant, and eventual liver cancer. This is what happens with cirrhosis. 45% of patients on the waiting list for liver transplant have hepatitis C cirrhosis. We need to change that. We don't have enough livers. The worst is yet to come, folks. Hepatitis C, as I told you early on, was an epidemic back in the 70s and 80s. And this is where we are now with 25% of the HCV-infected patients with cirrhosis, soon to be 40% into this decade. Just think about it. If you're taking care of these patients, it's only going to get worse. Years of life reduced in response to chronic hepatitis C infection compared to smoking, compared to the average. And here's the reality. If you treat patients for hepatitis C and cure the virus, this is what happens. Decompensation goes from 14% over a 2-year period to 1.4%. Liver transplant need goes from 11% to less than 1%. Likelihood of cancer goes from 9 to 1.4, et cetera, et cetera. Liver-related death also goes down by 90%. As a consequence of this, the CDC proposed screening all baby boomers. You don't have to screen them with any form to see if they have risk factors, just screen them. We know that their prevalence is at least 3.5%. Certain subgroups of baby boomers have a 9% prevalence of hepatitis C. Screen the baby boomers, please. This just shows you where they all are. For those of you born in the 50s, there you go. Think about it. You know the risk. I said, do you screen for hypercholesterolemia? Do you screen for breast cancer? HIV testing? It is more cost-effective to screen for HCV than any of these things to the right. Bullet point. 82% of patients with chronic hepatitis C were born from 45 through 65. Please screen them because you are the access to care. In the interest of time, I'm going to jump to one slide here and just talk to you about it a little bit. Project ECHO, Extension for Community Health Outcomes, brainchild of a colleague of mine in New Mexico, Dr. Sanjeev Arora, whose clinic in the early part of the previous decade was so overrun with hepatitis C patients he couldn't see any other liver disease. Moreover, in New Mexico, like other parts of the West, a lot of patients with diseases live hundreds of miles from an urban center, and they need therapy that they don't often get just because it's challenging. So he started using the web to deliver health care for chronic complex disease, namely hepatitis C, in rural and underserved areas. He was using the current information technology highway to deliver care and to train primary providers to do so. And I'm just going to jump to this Hollywood Squares image because we're running out of time. What is this? This is a Project ECHO clinic with providers that dial in every Friday to be coached by myself, a clinical pharmacist to keep us out of trouble with drug-drug interactions, and a psychiatrist who is the most important person at the table with these patients. We spend an hour and a half listening to case presentations, no patients. These are all providers, half of whom are APCs, advanced practice clinicians, NPs, PAs. They're providers, by and large, out away from urban areas. They may be in a clinic by themselves. They may be in a small clinic. Within a few months, under the mentorship of Dr. Arora in New Mexico, colleague of mine in Phoenix, myself, or John Scott in Seattle, we are using case-based learning and Project ECHO to train primary providers to deliver care. If we screen like we should, we're going to have 4 times more people to treat than we have already, and we're running out of treaters. We have to pass this on to the primary care base. We can do it. We trained them. Dr. Arora published 2 years ago in the New England Journal of Medicine the results of the first 500 people he treated in New Mexico with Project ECHO. His results from his ECHO sites were exactly the same as he got at his university practice. It can be done. There's nothing magic about it. It's just learning, being confident, being capable. They're backed up. They're backed up by me. They're backed up by Dr. Arora. They're backed up by our psychiatrists. They're backed up by our clinical pharmacists. A very effective way to address delivering health care in remote areas to people who otherwise couldn't get it at exactly the level they'll get it in an urban center, and you do it cheaper. And you do it well, and you create little mini specialists all over the country. Our ECHO goes from Northern California to eastern Wyoming to the Canadian border down to Arizona. It doesn't matter where you live. You get on the web at 11:30 on Friday. You start developing friendships with all these other people around you. This is actually Anne Hathaway from the family practice residency. And we've got her residents learning to do this as well. So that is Project ECHO. We're doing it for HCV. You can do it for any common complex disease, rheumatoid arthritis, complicated congestive heart failure. The VA has adopted it for diabetes mellitus. I encourage you to consider it. I appreciate your interest. Thank you very much. We have a few minutes for questions if there are any. Yes, ma'am.
You say that the CDC says to go ahead and screen them. Do you just do that on a physical? Do they pay for it? What code do you use?
There is now a code since the CDC made that recommendation about a year ago. I'm sorry I don't know the number, but I will get it to you.
All right. And then, so many people fall out of treatment or choose not to have treatment. As a primary care physician, how do we monitor them on a yearly basis? Do we check PCR levels every year? Do we have them see the gastroenterologist once a year? Do we ignore it because they don't want to have treatment? What do we do?
So what I've learned from my participation in Project ECHO, this is a very doable task at any level. It's really the transition to treatment that is the challenge. As far as monitoring these patients, what you want to do is learn a little bit about the disease so that you know those patients at high risk for cirrhosis. And those patients you want to monitor probably twice a year rather than annually. It's not their liver test, but you want to look for indirect evidence of advanced fibrosis, advanced scarring, leading to cirrhosis. Those are the people that must be treated now.
Okay, so what you're saying, like maybe ultrasound?
Ultrasound and a platelet count. The two most useful tests are an ultrasound because you can look at the shape of the liver, the size of the spleen, and get a sense of whether there's portal hypertension, and a low platelet count in a person with hepatitis C. Bingo. It's like, I'm afraid you're cirrhotic, I need a liver biopsy. You don't have to treat biopsy all these patients you want to treat, but if you're not sure they have cirrhosis, then that's when you need their biopsy.
Okay, and then also, if they're actively going through treatment, what happens when they get ill or having infections? What do we just treat them like a normal sick person who has an infectious disease, or do we have some precautions with these medications?
So we have a well protocolized approach to managing the patient and following them for evidence of impending problems. And when problems arise, if it's due to low white cell count, low platelet count, we address that with proper dose adjustments. If they get an infection, you're going to treat them just like anybody else you treat with an infection. They're not that much different. These drugs don't suppress their immune system. In fact, they upregulate their immune system with the exception that it does drive down white counts. They are a bit intimidating, but really they're just like everybody else you have who gets sick.
What's the cost of treatment?
Okay, there's always somebody who wants to ask these challenging questions. Well, the reason that Project ECHO is so good is because it's really outstanding case management. I mean, you're spending $60,000 on a course of therapy, drugs, labs, physician visits, and so forth. Very expensive and not going to get cheaper as the new drugs come on. So it's a huge cost. It's literally like that much chemotherapy. So if you're going to start this, you want to pick your patients wisely. You want to get them through therapy and make them adhere. Yes, Dave.
On the screening, Terry, you said these viruses are not, or they hide, they're not replicating. When you screen people once, you need to screen them every year, every 2 years, every 5 years, or if you have the virus, is it always going to show up? And if it doesn't show up, are you then clean unless you're exposed somehow?
So the question is, what do you do about the changing or the fluctuating viral count? Well, first of all, once you have it, unless you're a very, very unusual immune-structured person, if it's chronic, it doesn't go away, and it doesn't dip down real low. The knowledge of a viral load is only important when you're treating. Once you know the individual has it, you don't really need another viral load until you're ready to treat. Most people get it on an annual basis, But it's not, you're not going to change your therapy. People don't spontaneously clear this. The 15% who clear it early. They don't clear it late. And so once a year at most, you might look at a viral load, but you don't really need to do so. It's always going to be there.
You indicated that most hepatitis C is due to IV drug use. And you said that out of the population of 2,000 patients, 40 would probably have undiagnosed hepatitis C. Does that imply 40 former IV drug users?
No, it doesn't, because patients who had blood products transfused before 1992 are at risk by none of their behavior. The blood supply was not cleaned up until 92. That's when we developed the first generation EIA assay for the hepatitis C antibody. So young women who had hysterectomies before 92, who delivered, got a transfusion or two before 92. Before 92, the risk of transmitting hepatitis C with the unit of transfused blood was 3% per unit. So you don't have to have been an IV drug user. But again, the vast majority of people that we are now seeing who are coming into cirrhosis likely are. And then there are also behaviors that have accelerated or made this process work, such as even moderate amounts of alcohol consumption is like putting gasoline on a fire, other comorbid conditions that affect the liver, use of other drugs that have hepatotoxicities. So you need to know all of that history to know the likelihood of cirrhosis. Yes, sir.
Yeah, you mentioned the hope for lessening side effects with the new therapies that are hopefully on the horizon soon. Can you give us a little more specific information from what you know of the clinical trials of those drugs?
So obviously the toxicities that are directly related to interferon will go away. Those that are related to the direct-acting antivirals about which we talked, which were anemia and GI side effects and rashes, are still going to be around. However, the second-generation protease inhibitor, Cimeprevir, that the FDA is looking at right now has much less anemia. It's only given once a day. So the magnitude of the anemia is going to go down. Quite frankly, we don't have enough experience to know about the rashes for sure, but we're not seeing it. And the GI toxicities that are so prevalent with this generation have gone away in the second generation protease inhibitors, but they're there with the polymerase inhibitors. So again, we're talking about phase 2, just a little bit of phase 3 clinical trial. We're only talking about 1,000 patients. So when we hit the community, that's when we're going to find out about it. But by and large, they certainly look more easily tolerated now. Yes?
With the high-fat diet, doesn't weight gain and fatty liver become a superimposed problem on what you're doing?
Absolutely. But the reality is that after the 12 weeks of high-fat diet, we give them 12 more weeks of interferon and we just beat it out of them. And with the next generation of drugs, the high-fat diet is not going to be necessary. Yes, sir.
Is there any possible of reinfection
Sorry.
after you've got to that point where they have a cure? Or do their antibodies protect them against reinfection from that strain that they've had in the past?
So first of all, the hepatitis C antibody that we measure is a non-immunizing antibody. They're never protected from that antibody. We don't know that there is an immunizing antibody. We're attempting to develop vaccines, but it is a moving target. Secondly, this is a durable response, regardless of how you achieve it and what era of interferon therapy it was achieved. The likelihood of sustained success is 99.92% if you have an SVR 24. And in the 8 patients out of the 1,000 who relapsed, they actually went back to risky lifestyles. So we don't know, for instance, what's going to happen if you take a person with a cure and perhaps do a bone marrow transplant. I haven't seen any clinical data to suggest what's going to happen there. There's almost certainly a few viruses hiding out. but it's a very, very durable response. One more question, and I think we're
In a normal 50-year-old without a drug history, with normal platelet count and normal liver functions, should we still be checking them
yes, sir.
for HCV?
Check them once, give them a clean bill of health. If perchance they got infected from dirty dental instruments, reusable medical supplies before we started throwing everything away, you're going to pick it up, and they'll be glad they did, because now we're going to make sure they don't develop a complication. Thanks again, folks. Appreciate it.